Welcome to Neuro Navigators, a MedBridge podcast where we conquer challenging topics in neurologic and geriatric rehabilitation. Our aim is to deliver actionable takeaways for physical and occupational therapy providers like you through captivating discussions with influential practitioners in our field. To receive continuing education credit for this episode and access bonus resources, make sure to check out medbridge.com. Hello, I'm your host, JJ Mowder-Tinney, a physical therapist with over 30 years of experience working with people with neurologic deficits, as well as the aging adult population. I have multiple certifications, including being a board-certified clinical specialist in neurologic physical therapy and a certified exercise expert for aging adults. Today, I'm excited to be joined by Jeff Walter, an expert in the area of vestibular rehabilitation. We'll be diving deeper into BPPV, including recent research and actionable takeaways you can implement right away. Welcome, Jeff. I'm so excited to get to meet you in person, and I can't wait to get going on this topic. I thought first, I'd love to learn more about you. Do you mind sharing a little bit about yourself?
Sure, JJ. I'm really happy to be here with you today for this podcast and discussion. I work in central Pennsylvania. I work within an ear department. I work with three different ENTs that just specialize in ears, so they're called otologists and a neurotologist, along with a group of audiologists and another physical therapist at a balance center. So it's a balance center within the ENT department at Geisinger Medical Center, which is in central Pennsylvania. I've been a therapist for 27 years. I've been at Geisinger for 25 years.
Oh, wow. That's a long time.
Yeah. You're supposed to say, "Oh, you look so young. I can't believe that." But you didn't say that.
Well, you do, but that's a long time to be in one place. That was
Yeah.
the emphasis.
It's a larger hospital, but yet it's in a rural type setting. So it's appealing to me because I feel like I can practice at a large hospital, but not wade through tons of city traffic to get to and from work. So it's a unique setting in that way. All the patients I see are dizzy or unsteady. I don't have a diverse patient population. So all patients I see have dizziness or balance disorders.
Oh, that sounds amazing.
I also have an interest in teaching. So I teach for MedBridge and do some continuing education courses. And then also here at our center, I do some research. My research interests have been in BPPV, which is what we're going to discuss today, vestibular schwannoma, and superior canal dehiscence. So those are kind of the different hats I wear. I also teach adjunctively at Misericordia University and the University of Scranton, which are physical therapy programs in Pennsylvania.
So you're not busy at all.
Yeah, stay busy.
Well, I was really excited because vestibular isn't my area, and I've heard so many great things about you with the courses that you've done on MedBridge, and just talking about. I didn't realize you were so focused. So, I mean, I'm really curious about you talking a little bit more about what attracted you to vestibular rehab and kind of how your passion in that area, especially since that's all that you see, has evolved.
Yeah. So it's interesting. When I was in physical therapy school in the mid-90s, we had a class. I don't remember exactly what the title of the class was, but basically every student got assigned a topic. And I got assigned BPPV just by chance. It was kind of just what was left. And I said, yeah, I'll take it. And so that was my first foray into it. And so I start researching it for the talk I have to give to the rest of the students in the class. And I'm like, okay, you got to be kidding me. So this condition's caused by these loose stones in the human ear, and then we're supposed to maneuver their head and it cures them. And so I was kind of actually skeptical about it as I learned about it. And then I also had an internship at a balance center that just started up at the University of Wisconsin, which is where I was. And that kind of introduced me to it and kind of fell in love with it from there. I think one reason, I guess I can share why I like it, was summarized really well recently by a neurologist I heard on a podcast who said there's two things in medicine I'm convinced work: penicillin and maneuvers for BPPV. And I thought, well, that kind of summarizes how I feel, as I wanted to spend my career focused on making a difference and feeling confident that what I was doing was maximizing how much I could help a patient. And I think this area really encapsulates that. And I also feel like it's pretty poorly understood, especially in the medical community, and the patients are underserved. So that kind of attracted me to it too, because patients are really gratified. The patients you can help are really, really gratified when you can help them.
I was going to say, it sounds very, very satisfying because I'm always joking in the neuro world that there's just only one area where you can do one thing and really make a huge difference and they can see it immediately. And so that's pretty exciting. And I know that's not true all the time because again, I'm just I know the superficial components of vestibular and you're a deep diver. So, but I think that that whole BPPV and the importance of it, especially because of a huge population that I see, the older adult. I'm just curious of why you think it's important to talk about this, especially for all these therapists who we aren't specialized in this area.
Yeah. So several reasons. It's emerging. There's more and more. It's always been difficult to determine causation with falls because falls are so multifactorial. So when you get into falls research, it gets a little messy because when you just look at one single attribute with the patient or one individual impairment, it doesn't always explain why they fall. But there's emerging evidence of the impact BPPV specifically has on reduced ADLs and your fall risk. So that's one reason I think it's important. And it's most of the common forms of BPPV are really amenable to physical maneuvers. And so if you get comfortable identifying the variants of BPD and treating them, you're actually with a physical treatment treating the disease process in a way, which is kind of unique. So if we, with an exam, if we capture that an unsteady patient has dense peripheral neuropathy, there's some suggestions we can make, but we can't resolve that underlying impairment.
Yeah, definitely.
But with BPPV, you can really get at that impairment and control it really well with the maneuvers and some recommendations to prevent it from recurring with the patient. So that's kind of what drew me into it and why I think it's important. I think it's still often under-recognized and missed both by therapists and definitely in a primary care setting.
Yeah, I mean, I just think the changes over, I mean, I guess probably longer, but that I really noticed in the last 15 years or so, the uptick in understanding vestibular and thinking about all those people out there who suffered where there was something that could make such a big impact, and when you look at the Cochrane support in regards to the treatment, I mean, can you summarize a little bit about that and what's out
Yeah,
there today?
overall, a good summary is I would challenge a therapist to find anything within the realm of physical therapy that really has the evidence base, the support that maneuvers do for BPPV, because it's Cochrane database supported, American Academy of Neurology level A evidence that maneuvers work. Same thing with the American Academy of Otolaryngology. Systemic review supported years ago, physical therapy journal. So there's really a nice evidence base for intervening. A lot of our evidence base is within posterior canal BPPV, and there's these other emerging variations of BPPV, but the common form we see has really a nice body of evidence behind how you test for it and how you manage it. And that's another thing that drew me into this.
And that's amazing because not only do you have the evidence, but it's not this, like you said, balance. There's so many different things that could be going on for balance. And then to isolate something as challenging, then to have the evidence that takes you directly to what you should do. And
Yeah.
that it actually makes the difference is just it's really very exciting. And I'm so always so grateful for my vestibular experts, because I know when I'm out of my realm. Like I know a lot about a little, and I also know when to ask for help, which I do a lot. But I'm curious. So I'm kind of a little selfish today, but I'm curious about what you feel you could share with us that any therapist out there, PT or OT, that we're not specialized, but we know that we could be seeing this a lot more, and what kinds of things could we be asking to identify it, to feel more confident, and to share with the vestibular experts, like, so I can go to you and say, this is what I found. Like, what are those important things?
Yeah, it's so important just to ask the right questions. And this is really a topic that's been looked at really well in the last 10 to 15 years. If you go back in time, there was a big emphasis on discerning from the patient what they were feeling as far as symptom quality, meaning beating up your 80-year-old patient with questioning, badgering them to determine, do you feel like you're going to pass out? Do you feel wobbly? Do you feel like you're spinning, floating, all these different terms? And what we've learned is patients are highly unreliable in reporting their symptom quality. So that's been shown to be the response to that type of questioning is highly unreliable. So don't trust it in your differential diagnosis process. It should be weighted down low. There's a big emphasis in the literature on putting your stock in triggers, timing, and associated symptoms. So let's go through those. Triggers means what sets off your vertigo or your dizzy spells. So with BPPV, it should be a change in the orientation of the head in relation to gravity, going from sitting to supine, rolling over in bed, tipping your head up high for things off a high shelf. Your ear has changed its position in relation to gravity. BPPV should not evolve spontaneously, meaning someone shouldn't be on their couch listening to this podcast and bang, go into an attack and a vertigo from BPPV. There are other reasons why that might occur, but we wouldn't expect BPPV to not have triggers. It should have triggers that are positional and not just any old head movement, because actually just generic head movement left to right when you're upright really doesn't shift the otoconia, the particles that cause BPPV in a meaningful way. You have to change your ear position in relation to gravity. It should last seconds. So there's your trigger. The trigger should be positional. The timing should be seconds, although sometimes patients overestimate. And there should be a lack of cochlear symptoms. So there's certain vestibular disorders that present with hearing loss or ringing in your ear. This is one that shouldn't. So BPPV should not present with what we call aural symptoms, which would be hearing loss and tinnitus as examples. So trust triggers, timing, and associated symptoms. Do not put a lot of weight in to what a patient feels. We almost feel like we should go back and rename the disorder because it's called benign paroxysmal positional vertigo. But a lot of geriatric patients, when they're suffering from it, just feel like they're going to fall. They just feel like their balance is off. They don't always have an illusion of rotation with it. So that's one major teaching point that I would share is don't neglect to check for BPPV, even though your patient's not complaining of vertigo.
That's the thing. That's it right there. I mean, that is so different from what, like you said, quality. It was all about this.
Yep.
This is the room spinning. Are you spinning? Is this happening? Is that happening? And it kind of reminds me, Jeff, I don't know. It kind of reminds me of like how we used to ask about pain 50 million times. And now it's like, no, it's the pendulum swinging. And now, I mean, it kind of sounds similar to that. And I thought that was still a big thing, but I totally get the triggers. That makes a lot of sense to me. And then the timing. Now, I just want to ask a clarifying. I always learned it was like up to 60 seconds. Now, you said something interesting, like patients may expand on that. Is that?
Yeah. So if you're prone to motion sickness, all right, so that's just your whole life have been easily prone to getting nauseated with vestibular stimulation. If you wake up some morning and roll over to get out of bed or sit up out of bed and you get an attack of BPPV, well, you may spin for 20, 30 seconds where you feel like it's intense rotation or imbalance, but then you might feel sick and unsteady for another 10 or 15 minutes. So when you talk to me, your provider, what are you going to say when we ask you how long your attack was? You're going to say it was 15 minutes, even though you probably only had nystagmus for 20. It's just because you're very sensitive to the symptom provocation. And the first time somebody has the disorder, especially the first day, they just tend to not feel well most of the day. And they're scared to move. And so they really have some difficulty specifying that it was only seconds because to them, the day was kind of miserable every time they would move their head.
That makes a lot of sense. Okay, I appreciate that clarification. And I think that, and then the so triggers, timing, and the associated symptoms was that you wouldn't have any kind of hearing
Shouldn't
or
have an acute
ringing.
hearing loss, shouldn't have acute tinnitus. Other associated symptoms you don't want to hear would be double vision, dysarthria, dysphagia, hiccups that won't stop, crossed sensory complaints, because those are all things that can occur with central origin vertigo, vertebral basilar insufficiency. So we shouldn't be hearing about those either, because BPV is a peripheral disorder.
So that's really, I'm going to make you say that again
Sure.
because I
Remember
think
your
that's a really, really important component if we're asking questions and someone's coming in, and because central versus peripheral, I mean, today we're pretty much assuming, okay, we have a foundational understanding of BPPV. And so now it's just some of this latest research or, emphasis that you've been finding. But I think that central versus peripheral is a really important piece so that we ask the right questions.
Correct. Yeah, especially if you're an ER provider or acute care provider, because it's becoming more and more common to get the therapist to see the patient, actually, the vestibular therapist to see the patient as quick as possible, because we're cheap and MRIs are not. And so if you can get really comfortable that the patient clearly has a peripheral presentation like BPPV, we don't need to radiate the patient's head with a CT scan, hospital admission, or MRI. We can forego that if we have pretty clear history for BPV and testing that supports it. One way to remember the central concerns are remember your Ds, because a lot of them begin with D: diplopia, dysarthria, dysphagia, limb discoordination. So a lot of them begin with D. So that's one thing you can remember. Not on the list, by the way, is hemiparesis or aphasia, because those are more anterior circulation stroke type complaints. So you really want to think about VBI. With VBI, those are the more common complaints we see. And vertigo, when it's vascular in origin, is almost always from posterior circulation stroke, not anterior circulation stroke. So vertigo is a very uncommon symptom in someone who has carotid distribution ischemia, but it goes to number one. It's the most common complaint someone has when they have a posterior circulation event.
That's really helpful. I like that a lot. And something else you said about, so are we seeing more vestibular therapists in the ED?
Yes, it's
Like, are they?
definitely, I think it's one of the top growing areas within like acute care PT is to get
Ooh.
an experienced vestibular therapist on board to try to weed out and treat peripheral origin vertigo, mostly BPPV, because it's quick and cost effective if you can identify that's why your patient showed up at the ER. We get a lot of referrals at our center that are patients that went to the ER. And you might think, why would you go to the ER with vertigo? If you're living by yourself and you're already at fall risk, for example, and you wake up some morning and you're getting vertigo when you change positions and you're scared to death of falling and or you're vomiting, it captures your attention. In fact, a study looked at in dizzy patients, if we just generically use the term, the patients that are most likely to seek medical care when they're dizzy are the vertiginous patients. Patients that have spinning type vertigo, spinning type dizziness are much more likely to seek medical care than if you're faint or wobbly on your feet. So vertigo captures human attention that there is something askew and they like to get a quick answer for what's going on.
Well, no, and I'm really excited to hear that because in case they are having a central problem, we want them there as soon as possible. But that's really brilliant. That makes a lot of sense to me to have more vestibular therapists in the ED because of the cost effectiveness. I think that therapists, I mean, again, you know this area better than I do. So the therapist, that's a great argument, so to speak, or a discussion point to justify what's the benefit of having a vestibular expert, on call or ready at the waiting for the emergency room.
I can't tell you, JJ, how many times if a patient hangs out at any medical center, including ours, long enough, they present with vertigo. And so if we don't capture that they just have BPPV, even though they do, it's very common now in the United States to start ordering tests and not touching patients. So we get CTs and MRIs and vascular studies. And eventually you find something that has zero to do with why the patient's there. And then they're off on that tangent treating or managing that issue, which has nothing to do with why they showed up at the ER. So a lot of patients with BPV get an excessive number of medical tests and consults for something that really can be managed with your hands in about 15, 20 minutes.
That is fascinating. I could see that happening too. Especially then you're distracted, you're chasing, you're going down a different rabbit hole,
Yep.
and then you never address the original problem.
Right.
And and then I just can't imagine the frustration from the patient standpoint and why it must be so satisfying for you because finally someone is helping them with
Yeah.
what they need.
It really comes down to, I might come off sounding the wrong way with this, but you have to be comfortable grabbing humans and moving them.
Yeah.
And
Hit me with
it's
it,
ama-
Jeff. That makes a lot of sense.
we I get a lot of medical residents that are with me, and it's just interesting to see how uncomfortable they are maneuvering somebody, just handling somebody and maneuvering them through positioning tests. Like they just don't feel comfortable using their hands on somebody's body to help them move and direct their head where you need it to stay. And that's a skill I think therapists really have. Therapists are very comfortable
Mhm.
hands on a patient, and a lot of physicians aren't because there's been a shift in medicine towards ordering tests and labs and not just doing a good bedside examination with patients. It's been neglected, I think.
Do they learn that? Do they learn that technique in medical school? I mean, I know that may seem like a silly question, but
I it doesn't I don't know. By the time they end up here in a residency, no, they don't apply it. I think it's probably reviewed in school. There was a study that showed that if you show up at the emergency room with vertigo, your likelihood of getting a Dix-Hallpike is 9%. Your chances of getting a CT scan are close to 50. So you have a five-fold chance of getting a CT scan in the Dix-Hallpike. And in my 25 years here, in patients presenting with positional vertigo, I've never seen a CT show anything relevant to why a patient has positional vertigo only. So it's kind of we're hitting them up with radiation and then neglecting to do the test that would identify an amenable cause of their symptoms.
so it sounds like there needs to be a big push to
Yeah.
not make. We're not making anybody do anything, but to make them put vestibular therapists in emergency
Yeah,
rooms. I
it
mean,
really
that
would
just seems
help
like
with cost
smart.
saving. Yeah, would help with cost savings, I think, too, not just in patient outcomes, obviously.
Yeah. Oh, that's interesting. Now at CSM, I was hearing rumblings about there's a lot more older adults with BPPV than we ever thought there was, and because they're not complaining of dizziness. Is that the
So here's a very interesting concept. So there's been a new term put on this, and it's called vestibular agnosia. So for those of you who don't remember what agnosia is lack of perception of a sensory stimulation. All right, meaning that you're stabbing my hand with the pen, but I have no perception of pain. Some, especially elderly patients or those with traumatic brain injury or head injury, can have a vestibular disorder like BPPV and have no conscious perception of it. In other words, they don't report feeling dizzy. And so you might be thinking, well, then why bother treating it? Well, they still fall and they still have nystagmus when you test them. So reflexively, it's occurring and they may be having falls and postural instability from it, but they're not consciously perceiving vertigo. So there's like, for example, a couple of weeks ago, I had a patient that was in their 90s, and all he told me was that he felt wobbly when he would arise from his recliner or out of a bed. That's all I got from him, that he felt like he was going to fall sitting up. So I'm like, well, this could be a lot of things.
yeah.
So we take him through a balance assessment, and we get the positioning test, and I put him back in a right Dix-Hallpike, and his eye takes off like it wasn't subtle nystagmus; it was robust. And I
Oh,
asked him when his head's back in a Dix-Hallpike, I said, I see the upbeat torsional nystagmus lasting seconds. It had a delay before it started. So it met all the diagnostic criteria for posterior canal BPV. But just out of curiosity, I asked him, because he never reported dizziness lying down in bed before to me in the history. I said, what do you feel? And he said, I feel fine. I said, are things in the room moving? He said, no, not at all.
really?
Just had no what we call oscillopsia, which is seeing things in your visual field dance. No sense of spinning. Didn't care one bit. But then I sat him up And with BPPV, it's a two-way street. It bothers you when you go back, and then the particles have to settle back down in the canal when you arise. And when I sat him up from a Dix-Hallpike, he started to fall backwards. So he had the postural instability, but like no perception of spinning. And we think that that happens when actually specifically there's pathways in your right temporal lobe that if they're damaged from brain trauma or dense white matter disease, you're just not getting that higher center perception of your vestibular illusions is the way to think
Oh my
about it.
gosh, I haven't heard of that. So vestibular agnosia.
Vestibular agnosia is the term we're using for that.
Oh, Jeff, that's fascinating. So,
Yeah, I
okay,
agree.
that's
It's
really
really
cool.
interesting. And that's why I think a lot of geriatric patients can be missed. A recent study looked at how common BPPV was in a falls clinic. So just these are just patients coming in that are having repeated falls. And within a falls clinic, 40% of the patients tested positive for BPPV. A number of them had multiple canal BPPV. And what was interesting in their study, 25% of them had no conscious perception of feeling dizzy. They just were having falls. So we probably need to go back and revisit the diagnostic criteria for BPPV because as of right now, it necessitates currently that the patient reports symptoms with position changes, but I'm telling you, a substantial number of patients do not, especially geriatric patients or those with traumatic brain injury or head trauma.
That is so helpful because when they were talking about it at CSM, again, I didn't go to those talks, and I was just like, "What? Like that? Does that make sense? Like, is that a real thing?" So you really summarized that exceptionally well. And I'm just thinking, when you're treating someone, I always tell therapists, you're always asking why, and if they continue to lose their balance, and you're just like keep doing treatments, and there's not a difference, you have to have some other of these thoughts that, oh, what if this could be going on, like it just, but they didn't complain of dizziness, so of course I mean, me personally, I wouldn't have thought of doing that. So,
Yeah.
oh, that's so helpful, thank you so
I've
much.
found from my experience that sometimes we overestimate age. Well, my patient's just falling because they're getting older. I really disagree with
Grr.
that. I think when patients
I don't like
come to
that.
you because they're having balance problems or falls, it ain't just normal aging. I think that that's rare. It's rare that I'm done with an encounter with a patient and I sit back and I say, well, darn it, you're just old. Like
Yeah.
usually there's an impairment you can find if you dig hard enough. And I think one under-recognized cause of falls that we miss is BPPV.
Well, that is so helpful. Now, I mean, on that line, is there any other recent evidence-based advancements when you talk about testing for BPPV?
Yeah, so one is based on a study we did at our center. And I think this is a real practical thing you could take away from this talk is so the standard test for identifying BPV, which probably most of the occupational and physical therapy audience is aware of, is the Dix-Hallpike test, which just as a review involves your patient's supposed to be sitting upright. You turn their head 45 degrees. If you're testing the right side, turn it ipsilateral to the right. And we drop their head back over a pillow or over the edge of the bed. By the way, it doesn't matter which. And then you want their head extended about 20 to 30 degrees back. And so there's numerous studies that suggest the sensitivity of one Dix-Hallpike is around 80%. So you have a 1 in 5 chance of getting a false negative. So don't view one Dix-Hallpike as sufficient for ruling out BPPV. So repeated testing is advised. But we looked at a modified way of testing patients, and it's called the loaded Dix-Hallpike.
Ooh,
So what
haven't
we
heard of
looked
that.
at was turning the head 45 degrees, no different than your standard Dix-Hallpike, but then taking your patient and inclining their head forward. And what that does is it migrates the debris in the posterior canal towards what's called your cupula. It just shuffles the debris further forward in the canal so that when you then drop them back, the debris traverses through a longer distance. So it has
Ooh,
longer to travel migrating at its, while it's trickling through the canal. It has a longer excursion. creating pressure for a longer period of time, creating nystagmus for a longer period of time. So with our study, we were able to show that making this modification, which is just inclining your patient forward 30 degrees before doing a Dix-Hallpike test, really enhances the sensitivity, because we were up to 95% sensitivity with doing a loaded test. The nystagmus lasted substantially longer with loaded Dix-Hallpike testing versus standard. The one negative to make you aware of is when you ask patients what created stronger symptoms, the loaded Dix-Hallpike creates stronger symptoms. If you have somebody who's really, really sensitive to it, you may not want to do a loaded Dix-Hallpike because it creates stronger symptoms. But if you want an answer quick and you don't want to miss it, it might be advisable to do this modified version. We're going to include a video of the loaded Dix-Hallpike. It's a MedBridge video showing the clinician how to apply the test to this podcast. So if you want to see it in video action after the podcast, feel free. We're going to attach that to this podcast. So again, it's called the loaded Dix-Hallpike, and it's a simple modification to your traditional Dix-Hallpike testing.
Well, and it makes a lot of sense.
Right.
And I'm glad you're including the link, because when you bring the head forward, how long do you have to bring it forward?
In our study, we waited 30 seconds. In reality, that's what we did on our study protocol. I think it's overkill. I think probably 15 to 20 seconds is sufficient, because the debris is moving a little, but not that far. I don't think it takes that long for the debris to shuffle forward in the canal up against what's called the cupula. The base of your posterior canal, if you can imagine the base of it, interestingly, what we've learned is your semicircular canals are not perfectly circular. They're like a bent bike tire. And think about the base of your posterior canal for a long stretch is actually fairly parallel with the ground. So imagine if you have a canal that's fairly parallel with the ground, the debris can be anywhere along that parallel. If it was perfectly circular, it'd be at the lowest point. But your canal's not perfectly circular, especially the base of your posterior canal's fairly parallel with the ground. So compelling it forward allows it to fall back more when you put the patient back. So we do that in a lot of patients. I think it's really helpful in picking up on mild BPPV too. We had some patients in the study that we did that every Dix-Hallpike was negative, and we didn't see it until we did a loaded Dix-Hallpike. So there were some subjects that if you didn't do a loaded Dix-Hallpike, you didn't see that they had BPPV at all.
Well, that 95%, that's huge.
Yeah. If you can,
success. I mean, that's just, and it makes a lot of sense. It's so funny because, that test has been around for a long time. And, but when you think about the anatomy, it makes a lot of sense.
Yep. I just learned from experience that inclining the patient forward, when I had a patient who I thought had BPPV, but I couldn't get it to trigger, I just learned that if I inclined them forward and then brought them back, I was more likely to get a positive. And I said, well, I might as well prove it with the study. And in the midst of doing the study, there came out more details about the anatomy, and then it made a lot of sense why it was more sensitive. So I kind of got the anatomical reason for why the test was more sensitive during the study, which was actually helpful because then it made sense why it was more sensitive.
Wait, so are you saying the loaded Dix-Hallpike is you, Jeff? Like you?
Yeah, I came up with the idea, and I did the study at Geisinger with a resident named Luke Andera.
That's awesome.
Yeah, you can view the study full print, and it's not a difficult read. If you look up, just put in Walter, that's my last name, or Andera, Andera, to PubMed.gov and put in loaded Dix-Hallpike. It should be the first thing that comes up, and it's free access. You don't need like a subscription. It's in the International Journal of Advanced Otology.
Wow, I feel like I'm talking to a celebrity. Came up with your own thing. That's very exciting though, because that could be helpful to a lot of people. And so you talked about vestibular agnosia, which I found fascinating. You mentioned something about extending the head or using a pillow is fine. Are there other barriers to whether it's identifying or BPPV or performing the tests? Anything else you want to kind of add for the therapist?
So just as, if we deal with older adults, you just more commonly run into postural restrictions, especially kyphotic posture or cervical spine mobility limitations. Don't let that stop you. There's commonly ways around it. One thing that's really helpful is I use a high-low tilt table. But if you don't have a tilt table, that's okay. If you are anywhere where there's hospital beds, all hospital beds tilt. So if you have a patient that does not have adequate extension, you go to screen their cervical spine and they can barely get their head back to neutral. Do your Dix-Hallpike, but do it on a tilt bed with the head end down 20 or 30 degrees so that you're getting their head low, but you're not putting stress on their cervical spine. So I would strongly recommend the use of a tilt bed or tilt table for those that have mobility restrictions. And there's also a modified version of a Dix-Hallpike done in side lying. So instead of having your patient supine, you can do what's called a side lying test. It was first published by Helen Cohen years and years ago. But you turn the head contralateral 45 degrees, and then all you have to do is lie the patient down to their shoulder and let their head drop to the bed. And that's really helpful for patients that have back pain. It's a modified version of the test. The disadvantage to that test is it's a little harder to treat your patient, but if you just want to identify, the side lying test works really well. Physicians like learning it because you barely have to touch the patient to test them. You honestly can tell the patient what to do and just sit back and almost watch and just direct their head a little bit. It can be very hands-off that way. So that's another modified version of the test I would recommend. I'd always recommend too having a draw sheet under your patient so you can position them where you want to when you're working with them when they have mobility impairment. So that's another thing to think about.
I know, because that is really common. The spinal mobility really throws people off. And I would say also, I'm just curious because like, I know how important the goggles are for identifying, but like, I've never had the goggles. I can't imagine asking to have them purchased if you didn't have the vestibular person there. I mean, what are your thoughts on
So
that?
what I tell students when I teach them is you not having goggles is no excuse to not check for BPPV. And here's the reason. With the common variant of BPPV, which is posterior canal involvement, which if you sum up studies, it's like somewhere between 70 and 95% of patients with BPPV. The prominent nystagmus we see is what's called torsional nystagmus, which is your eye like twisting like a screw going in and out of a board. All right. So it's moving in a frontal plane. Whether you have goggles or not, that nystagmus is there. Humans can't suppress torsional nystagmus. So one advantage of these goggles is you can put a patient in darkness and they're not fixated. And so with horizontal and vertical nystagmus, you see a better show, like the nystagmus is accentuated, but torsional nystagmus, what we see with BPPV, is not suppressible. Humans can't suppress torsional nystagmus. So it's there in room light, or it's there if you use goggles. If you don't have goggles, you do need to be more vigilant when you do the test. So when you get them back, you need to hone into what one eye is doing. You don't need to really watch both. They both do the same thing if they're both plugged in.
That's a really helpful tip. So just look at one eye?
Just one eye, yeah, unless it's prosthetic or something. As long as it's plugged in and you screened and they have normal ocular range, just focus on one eye and focus on a blood vessel in the white portion of the patient's eye, which is called your sclera. That blood vessel's embedded in there. And just see what dance the vessel's doing. If you see it jumping towards the patient's eyebrow, they have upbeat nystagmus. If it's jumping fast phase towards their toes, if that blood vessel's moving, up slow, down fast, you have downbeat nystagmus. If there's torsion, you'll see the vessel moving like a handle on a clock back and forth. So watching what the blood vessel does during the test is helpful because that's telling what the eye's doing. And also when you get the patient back, pry their eye open. Take your thumb right under their brow and prop their brow up because an ingrained response in patients is when you invoke vestibular suffering is eyelids clench shut. So it's important that you keep your patient's eyelid open during the test. So don't be afraid to pull their lid open. I'll tell you that they'll much prefer you prop their lid open than for you to say, well, I really didn't see your eyes. Let's do that test again. They're going to prefer that you had propped their lid open during it.
Where have you been all my life, Jeff? Those are really, really great tips. And you're absolutely right. Like if you're a little hesitant to be lifting someone, they don't want to do it again. Right. So It's really a good call.
Right.
So, oh my gosh, there are so many good things that you just talked about, but I'm wondering if you had, like for maximum impact, your top three, I'm always about the top three takeaways that clinicians should take from our little chat, what would you emphasize?
Yeah, let me hit one more thing I wanted to touch on before we get to that, and that's BPPV prevention, just briefly. There's been a lot of recent evidence that perhaps low vitamin D levels are linked in with BPV. We know that women get this more than men, and it's linked in with bone density. So if you have osteoporosis and osteopenia, you're at higher risk for BPPV, and that's why it's like, oh, if you look at most studies, it's like 1.5 or 2 to 1 female. So it's definitely more common in females, which, by the way, bad combination there. You have BPPV creating positional vertigo along with weak bones, so that is your recipe for falling. Also, if you have dementia, there's your ultimate recipe for having falls, because patients with BPPV quickly learn what they shouldn't do. But if you have dementia or memory impairment, every time's the first time. So that combination's a recipe for hip fracture: dementia, weak bones, osteoporosis, osteopenia, and BPPV. And the most modifiable of those three, in my opinion, is managed BPPV. But anyhow, getting back to prevention, if we have now at our center anyhow, and I can't speak for what everybody else is doing, if I have a patient who's a frequent flyer, like has recurrences, because it can recur for some patients, or if they just dread getting it back or at high fall risk, we're checking their vitamin D levels. So we order a lab to check their serum D levels. And if they happen to be low, we advise they treat them. So there's clearly low D is clearly related to increasing your risk for BPV. And there's also some recent studies that suggest treating it might prevent BPPV recurrences. So that's one thing you can do to possibly prevent recurrence. The other thing you can do is actually sleep with the head end of your bed slightly elevated. So just slight inclination of the head end of the bed. And so that prevents the debris potentially from getting entrapped in the canal in the first place. That's been about the only thing that's been shown to help prevent BPPV recurrences, is slight elevation of the head end of the bed. So I tell patients to put blocks under the head end of their bed, so their bed's on a slope, head up, a small wedge, an extra pillow, put a blanket roll underneath the head end of your mattress so your mattress just slopes up a little bit. Now you can't go, they need to sleep. So you have to, as much elevation as you can tolerate, but yet still sleep well. So those are two things that you could suggest to your patient who's had recurrent BPV, who's really at high risk for falls with it, is to prevent it. Incline the head end of the bed and consider getting your vitamin D level checked.
Oh, those are perfect. And they do have those little wedge things that you can buy to put under the mattress.
Yeah, I believe you can get them in, don't quote me, but I think 3, 6, 9, and 12-inch. So I don't hardly ever tell anybody to get 12. I couldn't sleep on a 12-inch wedge, but just, whatever you can tolerate, 3 or 6 inches, just a slight inclination of the head can potentially be really helpful in preventing recurrences.
Sounds like every little bit could help.
Right. So back to the 3 take-home points. So,
Yay!
and this was a commentary by Sue Whitney and some colleagues back to I believe it's called the International Falls Organization. Anyhow, an international group that looks at falls and guidelines for managing falls. So their current guideline is that BPPV should be checked for if a patient complains of vertigo with position changes. And they're advocating, we would suggest that you check for BPPV in everyone who is falling, which I agree with that, because we just went over vestibular agnosia and how many patients won't overtly complain of vertigo, especially elderly that have the disorder. So if your patient's having frequent falls, I would just suggest you incorporate positioning tests, at least a Dix-Hallpike. There's also what's called a supine roll test for horizontal canal involvement, that you incorporate doing positioning tests and consider the loaded Dix-Hallpike in that to identify patients that have this correctable disorder. So that would be one take-home point. And then remember what we talked about earlier. Don't over-rely on symptom quality when you take a patient's history, and only think of vestibular when you hear the word vertigo, because you're missing a ton of patients. All right, so don't get too locked on to the adjective they use to describe what they're feeling. Trust more the triggers, timing, and associated symptoms that they experience.
We need to shout that from the rooftops, right? Because I mean, that was ingrained in my training, or
Absolutely.
from
Yeah,
going
if you
to
look at
school.
older textbooks, it used to be if they're faint, it's cardiovascular. And if I've had tons of patients with BPV, I sit them up and they'll say, I feel like I'm going to pass out. Have you ever actually passed out? No, I've never passed out, but boy, I feel like I could. And their eyes are chugging on my TV screen. Like I see they have nystagmus with it. And you would think they'd feel like they're spinning or unsteady, but that's just the way their brain processes it, that they just feel floaty or lightheaded when they have it. So again, don't get too locked into symptom quality. Look at those other factors when working with the patient. Keep in mind that BPPV shouldn't arise spontaneously with oral symptoms or CNS symptoms. It should be positional, lasting seconds with postural instability, maybe spinning, maybe a sense of lightheadedness. So those are some, I think, take-home points from our discussion.
Well, and come on, loaded Dix-Hallpike. I'm loving it.
Yeah.
I'm sorry. I just think that makes so much sense, and I'm rather excited.
Right.
I can't
No,
wait
I
to
want to
see
be,
that article.
I don't want to be, since I published it, I'm trying not to be biased here.
That's right.
Again, remember the negatives. The positives with that are enhanced identification, a longer show for you to see when you do the test, and the nystagmus should last longer. The negatives are your patient may not like you as much when you're doing the test because it can evoke stronger symptoms. And the other thing is it does take, if you follow the protocol that we wrote in the study, it takes 30 more seconds to do each side. So it's another minute of your time versus standard testing. So I want to present the positives and the negatives, and those are both sides of the ledger there.
Well, I appreciate that. And I think that, just to get started, if you're like me, first feel really good with the Dix-Hallpike. But I think understanding why that loaded Dix-Hallpike was, indicated more makes a lot of sense. And so I just think that can be helpful.
One thing I didn't mention just briefly is you don't need to do positioning tests violently. This disorder is not dependent on you jerking your patient's head around with high velocity. It's a gravity-dependent phenomena. So imagine if you turned a snow globe upside down. If you just turn it upside down steadily, the debris is going to settle in the snow globe. If you turn it upside down quick, the debris is going to settle in the snow globe. You don't have to, with rapid acceleration, test your patients. Because I think some therapists steer away from doing positioning tests because they think it has to be done real quick. And then they feel like not safe with the patient. Just steady movement with these position changes are adequate. When we do a Dix-Hallpike, I would say it should take you like a second or two to get there. You don't need to get there in a quarter of a second. All right. So it doesn't need to be a rapid acceleration. That's been studied mechanically. That's not just opinion.
Well, sorry. I appreciate you saying that as number 3, because that has changed over I ask a different vestibular therapist, I get a different answer on that.
Yeah.
And I've always been nervous about, how fast do I have to go? But I think your snow globe visual is extremely helpful. It's like, well, that makes sense. Like, you're right. Why do we have to?
There's biomechanical studies showing that rapid acceleration adds very little to your Dix-Hallpike. That just changing the position in just a steady way with your patient is adequate. Don't do your Dix-Hallpike in segments. Don't inch them down, but just put them down steady.
Got it. Wow, Jeff, you gave me so many key things that I really feel, for not being an expert, or hopefully even those experts, just reinforcing some concepts. So I'm hoping that we captured everybody. But I know I have just learned a ton, and I really appreciate your time. And I have a feeling we could talk all day, but that's all the time we have for today. Right. So thanks again to Jeff Walters for his insight and clinical takeaways relating to optimizing BPPV management in older adults.
Thanks, JJ.
Thank you for tuning in to this episode of Neuro Navigators by MedBridge. Please be sure to subscribe and listen to more of our episodes on Spotify or your favorite podcast platform, and at medbridge.com. If you're listening outside of the MedBridge catalog and would like to access the bonus resources and receive continuing education credit, simply log into your MedBridge account and search for this episode to find the accreditation details. Neuro Navigators also listens to you. If there is a particular clinician that you'd like to hear from, or if you have a clinical question or challenge that you'd like to see addressed on this podcast, please let us know by leaving a comment on our Instagram posts or by emailing podcasts@medbridge.com. As we wrap up today, remember that your dedication makes a difference. We appreciate you being here to navigate these topics and hope you enjoyed our deep dive into everything neuro. See you next time.